Hi there, and a very warm welcome to another episode of Today's Parent, where we connect you with experts and provide you with information to make your parenting journey a bit more easier. I'm your host, Christine Casina, and today's episode we are talking about polycystic ovary syndrome. It happens to a couple of women. Actually, I hear the statistics are quite grim. 30% of women are affected by PCOS, and it can cause infertility. In studio today, we want to have this conversation, and we have an expert, Dr. Kireki. He's a fertility specialist and has a great of knowledge when it comes to reproductive health matters when it comes to women. Dr. Kireki, welcome to the show.
Thank you very much, Christine, for welcoming me.
No, good to have you as usual. Very nice to have you again.
Yes.
It's called PCOS.
PCOS, meaning polycystic ovary syndrome, or others call it polycystic ovarian syndrome.
All right.
This is a newish name. Let us put it that way, because earlier on it was called a different name. It was called Stein-Leventhal syndrome.
I will not try to pronounce it.
Please don't. And this is because of the guys who discovered it.
Right.
They noticed that in some women who were obese, when they did a scan and they found that their ovaries were enlarged and they had some small, what we call black areas around them. And they also noticed something different, something else. They noticed that these women had issues. They had issues with getting pregnant. Their periods were very irregular. They were obese, most of them, not all of them. They also had issues with getting pregnant. They had issues with acne. They also had issues, by the way, acne is where you have ladies who have...
They break out.
Yeah, they break out quite a bit.
Okay.
They also had issues with hair in different places. Most of them had hair around the chin, around the nipples, around the abdomen, what we call typical places where men normally have hair,
and women
are not supposed to have it. And apart from that, some of them had what we call alopecia. Alopecia is basically what we call male pattern baldness.
Right.
Just like mine, it's gone.
Okay.
It's not supposed to be there for women. So they actually are the ones who published the first articles about this.
Okay.
And then later on, actually, they changed that name to polycystic ovary syndrome.
Okay.
Which is what we are talking about today.
So what exactly is PCOS? What exactly is polycystic ovarian syndrome?
Now, actually, the name itself is a misnomer. Meaning it is a name which actually doesn't fit where it's supposed to be.
Okay.
Because when we talk about polycystic, it means there are many cysts. Now, in medicine, when you talk about a cyst is anything which has something in it. It can either have fluid or it can have other tissues in it.
Right.
So when you talk about an ovarian cyst, we can have what we call a simple cyst, meaning it has clear fluid in it. We can have a hemorrhagic cyst, which has blood in it. We can have what we call an endometrial cyst, which has old blood in it, in endometriosis.
Okay.
You can have other cysts, mucinous cysts, and so on and so forth.
Okay.
So the cyst is described based on what is the contents which are inside it. Now, in polycystic ovaries, we actually don't have those cysts per se. What we have is basically an ovary or ovaries which have small follicles, and normally a follicle is what carries an egg.
Okay.
But now these follicles which are in these ovaries are quite many of them. So because of lack of a better word, they called it polycystic ovary syndrome or polycystic ovarian syndrome.
All right.
So they are not really cysts as per the proper definition of a cyst. Okay. And then the size of the cyst as well. When you talk about a cyst usually in gynecology, anything over 2.5 centimeters or more is what you call a cyst.
Right.
But these ones are usually tiny. They're about 10, 11, 12 millimeters. So they really actually don't qualify to be called cysts, but that is the way nomenclature is, and we've accepted it the way it is. Yeah.
So how many women on average are affected by PCOS?
Now, in my practice, and I see quite a number of ladies who are having issues with trying to get pregnant, I see about 2 to 3 patients on a weekly basis who have these issues.
That's a big number.
It's a big number because statistically, in the literature, they say anywhere between 20 and even up to 30% of women who are trying to get pregnant, who have issues with infertility, have actually a problem with polycystic ovary syndrome.
So in most cases, it gets to the point where they're trying to get a child,
Yeah.
is then you notice something is off, and then they get diagnosed with
polycystic. Actually, they come in two ways. Well, some of them will come and say, you know what, my periods are very irregular. I don't know when I will have a period, so what is happening?
Right.
So when we do diagnostic tests, when we walk through the history, we find out it's a high degree of suspicion that she could have polycystic ovarian syndrome, only that when we do now tests to confirm that, it actually comes out that they have polycystic ovaries.
Okay.
Now, the other group are the ones who have been trying to have a baby, been trying to get pregnant, and they have regular intercourse, no contraception. 2 years have passed, 3 years have passed, and nothing is happening. So when they come and we run the tests on them, we actually do find that they have polycystic PCOS,
right.
or what others call PCOS, polycystic ovary syndrome.
Okay.
Yes.
For any woman who's watching right now, hoping not to get to the point when they're trying to get pregnant,
yes,
is when they discover that they have, PCOS.
That's right.
How can you watch out for the signs? For acne, how can you tell that your acne is not the usual breakout?
Yes.
Or for, I know a lot of women have 1 or 2 hairs. Do
Yes.
they need to worry? Or when it becomes a full beard, when do you need to worry?
I think these are very valid questions. You see, having hair here or hair there does not qualify straight away for polycystic ovary
right.
syndrome, because there can be other issues as well, what you call endocrinopathies.
Right.
We can have some tumor or tumors which actually produce the male hormone testosterone, and this can actually lead to women having hair where it is not supposed to be.
Okay.
So we also need to have that at the back of our minds when we are dealing with these patients with polycystic ovarian syndrome. Is it that there could be something else that could be producing testosterone that could actually be leading to that? So we don't only look for one thing, we look actually for 3 things. When a patient comes with suspicion of polycystic ovary syndrome, there is a criteria that we actually use,
okay.
And it is called the Rotterdam criteria. And basically there are 3 things we look at, and 2 of them have to be there before we can actually diagnose and confirm polycystic ovary syndrome. One is what we call irregular periods, or very scanty periods, or there is no ovulation, what we call oligo or anovulation.
Right.
So that is one of them. The other one is hyperandrogenism. What do we mean by that?
Yeah.
It basically means that you have a high level of male hormones. And how can that manifest itself? It manifests itself in having hair where it's not supposed to be, on the chin, on the upper lip,
right.
around the nipples, around the abdomen, and so on. It's not supposed to be there. So that is the second criteria. And the third criteria is a scan. We do a transvaginal scan,
okay.
and we have a look at the ovaries. Now, when we look at the ovaries, there are two things that we look at. Number one, the size of the ovary, and those small, tiny black areas, which are called the follicles. We remember we talked about follicles, but they have to have a certain number.
Right.
They are usually more than 11 or 12 or more, and usually they are arranged peripherally around the edges of the ovary. So if we have that on transvaginal scan, and we have the history as well, the periods are irregular, or they are very scanty, and so those are 2 of them. And then when you add now the hair being found in other places, what is called hirsutism, then obviously this patient qualifies for the diagnosis of polycystic ovary syndrome.
So that is how you diagnose?
Yes, that is the international criteria, which is accepted, medically speaking, everywhere in the world.
Oh, okay.
Yes.
Okay. Let's talk about the effects of polycystic ovarian syndrome.
Yes.
How does it affect women?
In a very big way. In a very, very big way. Actually, it encompasses the whole body.
I can imagine.
Yes, because it starts with irregular periods or lack of periods. And we have issues with hair, which I have mentioned.
Yes, you have.
Because for ladies, sometimes you find ladies in a matatu and they say, huyu ana ndevu. Uko na ndevu. Kwani haukunyoa ndevu? it's horrible.
Yeah.
But you don't know what this lady is going through.
That can affect anybody's self-esteem.
Yeah,
it can.
especially for ladies, because they know we are not supposed to have a beard or, and so on, and they see it, which becomes a big problem. So there is that pressure. Depression can actually come in because of that. And remember, these ladies, most of them are trying to have a baby, and it's not happening. So that plus this, can actually throw anybody off balance.
So much to deal with.
Yes. Now you have issues with weight. Most of the ladies who have polycystic ovarian syndrome are either obese or they are overweight.
Okay.
That also is contributory to actually the problem that they have, because when you see these ladies who are overweight, when you ask them actually that if you can change your lifestyle, change how we eat. Instead of drinking a cup of tea in the morning and a slice of bread, and then in the afternoon you have something not so heavy, and then in the evening you come back is when you sit and you really eat those chapatis or ugali, nyama and whatever, and then you go to sleep. So actually you don't need those calories in the night. You need them in the morning. So if you can change that such that you have a heavy meal in the morning, in the afternoon you have something which is not so heavy, and then in the evening something very light. So we change the diet.
Yeah.
We change lifestyle in terms of exercise, because now you are accumulating less calories in the night. So you can actually, when you start an exercise regime, that will have an impact on the weight. If they reduce this weight by about 10%, over a period of about, let's say, 2-3 months, they actually notice a difference. Number one, the periods become regular.
Okay.
Number two, because of that exercise, that oxygen that gets into the system, the body releases what you call endorphins, and you feel actually better. Now, the sex life becomes better, whereas previously, with patients with polycystic ovaries, one of the problems they have is low libido as well.
Interesting.
So that one can be taken care of that way. We have other issues. Now, once the body weight has dropped a bit, the hormone levels actually do change.
Okay.
The androgens or the testosterone actually drops a bit, and then you find the body starts behaving differently.
Right.
So these are some of the things which can be done, apart from obviously coming in with medication later on. And again, it depends on what exactly this patient wants.
It's interesting that you mentioned when it comes to PCOS, it's more of something that we acquire along the way, not something that we inherit.
That one we are not very clear about.
Okay, so it's nothing. It has nothing to do with genes.
It
more of a lifestyle kind of.
It is most probably because you find some of these ladies, when you ask them, actually there was a study which was done in Australia, and they actually found out that about anywhere between 5 and 12% of these patients who are polycystic, who had polycystic ovary syndrome, somebody in their family also had the similar problem, either the sister or the mother or somebody else. Now, we don't have a gene which has been isolated. Like we know that there is a problem with, let's say, sickle cell anemia.
Right.
There is a gene, there's a problem there, which we can actually sort of sidestep. But in polycystic ovaries, we don't have. We don't have a direct gene. Say, okay, Christine, if you have this gene has been isolated in your blood, then you have polycystic ovary, or you have polycystic ovary and we have isolated this. We don't have. What we have is basically indirect information that a sister or a mother or somebody close to you has had this problem before, and you have it. So then there is a high probability of it being genetic, as it were.
So what makes you, to understand you correctly, what makes you predisposed to get PCOS? Number one is obesity, and number two, possibly somebody in your lineage has been affected before.
More of the lineage first.
Right.
Yeah.
Right. All right, we are going to take a short break. And when we come from this break, in studio today, we have Dr. Kireki, who's a fertility specialist, and he's well averse with matters reproductive health when it comes to women. We are talking about PCOS. When we come back, we are going to talk about if it's possible to get treatment and how you can manage. Don't go anywhere. Welcome back to today's episode of Today's Parent, where we are talking about PCOS also known as polycystic ovarian syndrome. If it's something that has affected you, I'm sure you'll find this show to be very insightful. And at this point in time, we are going to talk about how you can manage PCOS and get treatment. Dr. Kireki, what's the worst you have seen when it comes to PCOS?
The worst, I don't know whether you can really call it the worst, but I see a lot of ladies who have serious issues.
Okay.
And those issues are medical, and they're emotional, and they're physical as well. So when you put all of them together, you find these ladies have a lot of problems.
I wonder if you then have to work with a psychologist, a counselor, just to partner.
Actually,
and find a way to,
That is very important, because some of the things I may not be able to manage them, especially when it comes to the emotional bit of it. And they try to get pregnant, they can't get pregnant, they get chased away, and self-esteem goes down, hits the floor, and so on and so forth.
Right.
So it is best to manage these patients, in a holistic way. I do my bit, and then somebody else does her bit, and then we try and help these ladies,
right,
to achieve what they would like to achieve.
Treatment. What options are there for treating PCOS?
Number one, before we even go to treatment, diagnosis is very important.
Very important. Let's talk about diagnosis.
Yeah. So when such a patient comes to me, the first thing is to try and listen to her and try and understand what the possible problem could be. In medical school, we are taught that a good history, just listening to the patient, you will actually have 50% diagnosis made. So when these patients come and they tell you they have, and observation as well, they have a problem with their periods, they're trying to have a baby, and by the way, when the patient comes in and even sits there, you can actually see most probably what BMI, where it's supposed to be.
Right.
You can look at the facial features, you can actually see, even sometimes they may not tell you about, let's say, the hair in different places, but you can see it. So you can ask to affirm what you have actually noticed.
Right.
So history taking is very important. Let the patient tell you what she has been going through. Send them for tests, blood tests, hormone tests. We do a scan. As I told you, remember in the first part we talked about the Rotterdam criteria. So once you get these results back, you say, aha, it is a confirmation of what I was suspecting. So it's polycystic ovarian syndrome.
Right.
Now, treatment will depend on two things. It will depend, number one, on whether the patient wants to have a family, start her family, or she just wants to have regular periods. Those are two things, because treatment is completely different.
Right.
If it is a question of trying to have regular periods, most of the time what we suggest to the patient is for them to take oral contraceptive pills or hormones, basically, because then they will have a regular period every month.
Right.
So that is completely different. You can't use oral contraceptive pills and try to get pregnant at the same time, because
there's a conflict,
conflict. So that group of patients, oral contraceptive pills, or basically hormones, it could be plasters, it could be other things, that will help in regulating the periods.
Okay.
When it comes to the issue of trying to get pregnant, now this one is a little bit more complex, because we have to look at very many factors. We have to look at the age of the patient. We look at the BMI. We look at how long she's been trying to get pregnant. We do now extra tests. We find out whether her tubes are okay.
Okay.
We find out whether her husband is also okay, because that is and can be a factor as well. So if the tubes are fine, and we know it's polycystic ovary syndrome, and they're trying to get pregnant. Let's say, hypothetically, they've been trying to get pregnant for 2 years, and let's say she's 25 or 26. So relatively young, good age to get pregnant, and the husband is okay,
right,
and the tubes are fine. The first thing we want to do is, if she is overweight or obese, we want to help her change her lifestyle.
Okay.
Bring down that weight a little bit, and actually, when the weight comes down a little bit by about 10%, her periods become normal. Some of them actually do get pregnant naturally without any issues, which is fantastic. Now, if this doesn't happen, then we actually can do it in a multi-pronged approach. So we do lifestyle, we give them tablets, which actually are supposed to help, because normally a woman releases 1 egg a month. So with these tablets, we try and see whether she can release maybe 2 or even 3 eggs at the same time.
Okay.
So we do what is called a follicular tracking. They come, we do a scan, we see whether there is a follicle. A follicle is what carries an egg, and whether that follicle is mature.
Right.
So if it is mature, we actually induce ovulation, what we call timed ovulation, give them an injection, and then, now, if the semen sample is okay, the tubes are fine, we tell them, look, we've given you this injection, we have a window, 24 to 36 hours. In this window, have what is called timed sexual intercourse. So we tell them, tell their husband, asifanye kazi sana, ana kazi ingine atafanya. So we can do that. And they have what is called timed sexual intercourse. Now, depending on the age of this young lady, if she is 25, we can actually do that for 4 cycles, even 5 cycles.
Okay.
Some guidelines, the UK guidelines say even up to 6 cycles.
How much is a cycle?
No, this is just giving tablets and doing a scan.
Right.
And having timed sexual intercourse.
Okay.
So there is not much investment in terms of money.
That is good.
Now, if it doesn't work, then we can actually go up a notch higher, and say, okay, if this hasn't worked, we do what is called IUI. Basically, what that means is, again, we use the same medications. We do a scan around day 10, day 11. The husband gives us, we give them an injection. We know we have a window of 24, 36 hours. They come to the clinic. The husband gives us a sample. We clean this sample, and then we inject this sample into the womb.
Right.
So we remove all the debris, because we, in a semen sample, we may have sperm which are not motile, and so on and so forth. So we remove all this. So we inject the best sample into the womb.
Right.
We can do this a maximum again of 4 cycles, again depending on age. In the UK, they say even up to 6 cycles. So you see, if we were to do 6 cycles of this, 6 cycles of this, that is 1 year. In that 1 year, the chances of getting pregnant, all things being equal, is anywhere between 25 even up to 60%,
right,
depending on what we are doing.
Okay.
Now, if this doesn't work, we can now go back to the drawing board and say, we have done this, it hasn't worked, we have done this, it hasn't worked. There is something else which we can do, which is called ovarian drilling, laparoscopic ovarian drilling, where we drill a few holes, usually about 4 holes, on the ovary, on each side of the ovary.
Okay.
And it has been noticed that actually when you do this and use some medications, these ladies actually do get pregnant without any problems.
Right.
Now, if all these fail, then we have to come back and say, look, we have done step by step what we are supposed to do, and it hasn't happened. So we may think now of doing IVF. Now, before we even get to IVF, in the meantime here, in this, you remember we've been giving them medications, there are some medications also which can be given to actually help in the biochemistry in the ovary.
Right.
And these are usually medications which patients are given for diabetes, because we know that these patients who have polycystic ovary syndrome have what we call insulin insensitivity.
Interesting.
What does that mean? Normally, in a cell uses glucose for energy. Now, you find in these patients who have polycystic ovary syndrome, because of the altered metabolism which goes on, not much glucose actually does get into the cells.
Right.
So these cells don't work very well, especially the cells in the ovaries. So what we want to do is we want to sensitize these cells so that more insulin can actually allow more sugar to get into the cells. So these are some of the medications which can be used. So diabetes medication.
Okay.
There are other medications which have come into the market, which in Europe, for instance, they started using them about 3-4 years ago. But thankfully, in Kenya, they are in the market and they can be used as well.
All right.
So there are different ways which we can help these ladies, and we can actually combine all these methods. So we do these medications, whether it's the diabetes medication, whether it's the new medications which I mentioned about, which are called myoinositol, and the surgery, the ovarian drilling. Basically, what we want to do is to use as many ways as possible to try and help these ladies to have regular periods, and if they have regular periods, then the chances of them getting pregnant is a lot higher.
Which is a good thing.
Which is a good thing. Now, sometimes we have patients who are resistant to all this, whatever we are doing. We give them medications to try and produce more follicles. It doesn't work. You give them medications for, for the diabetes medication.
Right.
It works not very well.
Okay.
Well, for these ones, we have an option. We can actually use injections. We can use what is called FSH, where we give them injections every day for about 5-7 days. We do a scan and we see whether their ovaries have responded.
Right.
The only problem with this, or the only drawback with this, is that sometimes they end up producing very many follicles. And when they produce very many follicles like this, the chances of having triplets or even large number of babies is also very high.
That's a high risk as well.
Yes. So we have to warn them and say, look, we have 5 follicles on this side, 6 follicles on this side. Generally, we shouldn't go ahead and do, let's say, IUI or have timed sexual intercourse, because the chances of you having multiple pregnancy is very, very high. But some patients say, you know what, I've been trying for X number of years.
Let's go for it. Let's go for it.
Yeah, whatever happens, itakuwa ni ya Mungu.
Doctor, I know we are short of time. The one thing I would want to ask you, if there's a mom or a couple out there struggling with PCOS, if they want to get in touch with you, how can they get in touch with you?
They can get in touch with me. The phone number to my office is 0780 170 170, and I'm located at 5th Avenue offices, which is on Ngong Road, on the 3rd floor, 314.
Right.
And I'm usually in the office on Tuesdays and Wednesdays afternoon.
Thank you, Dr.
Karibu
A word of encouragement. You know, we've ended on a low note. For a woman out there, just a word of hope if they're affected by PCOS.
It is not the end of the world. Actually, it is a good thing sometimes to have polycystic ovaries, because these women, when they come for IVF treatment, they produce a lot of eggs, which is a good thing. But then again, the quality sometimes may be a bit questionable. But out of those many eggs, we usually get some very good embryos, and we do transfers, and they do get pregnant. So it is not the end of the world. Absolutely. We can manage it, and we can help you have these children.
That is good to know.
Absolutely.
Thank you, Dr. for coming. Always a pleasure to have you.
Karibu sana.
Always a pleasure.
Yes.
And with that, we come to the end of today's episode of Today's Parent, where we talked about PCOS. If you're afflicted, or you know anybody who's been affected by polycystic ovarian syndrome, please get in touch. We have our SMS number at the bottom of your screen. Send us your questions, send us any comment, and we'll find a way to connect you with Dr. Kireki. I hope you enjoyed today's show, and we hope to see you another time. We have been hosted here in studio at Little Cribs. It's the home of exciting, fun, durable, and affordable kids furniture. I have been your host, Christine Kasina. If you're looking for parenting information, head over to www.supermamas.co.ke. And before I go, if you're looking for other episodes of Today's Parent, you can find them on our YouTube channel, Switch TV. You'll be able to catch up on what we have been up to. Thank you very much for watching. See you next time.